Good evening. So today we'll be discussing about quick revision series in medicine for nephrology and fluids and electrolytes. So this will be useful for people preparing for competitive exams like NEET or INSET. So in nephrology, the basic is all diseases will be classified under three headings: pre-renal, intrinsic renal and post-renal. So we know this basic anatomy. So we have the kidneys. Following kidneys, we have the ureters. The ureters join with the urinary bladder, and we have the urethra. So anything beyond the kidney will be post-renal. So post-renal diseases will usually come under surgical or urological discussions. Pre-renal is any systemic disease which can damage the kidney. For example, when there is a shock, it can damage the kidney. If there is a disease in the heart, that is called as cardiorenal syndrome, that can affect the kidneys. Suppose if there is a disease in the liver, that can also affect the kidney. That's called as hepatorenal syndrome. So basically any disease other than the kidney which is damaging the kidney will be termed as pre-renal. So any problem in the kidney itself will be called as intrinsic renal diseases. So these are some of the examples for post-renal diseases like stones, blood clots, benign prostatic hypertrophy, obstructed urethra, etc. So this will not be discussing. So to understand intrinsic renal diseases, we must know the basic structure of nephron. We are not discussing much in detail about the nephron. So just to know about what are the structures which are present, the main structure is glomerulus. Glomerulus is nothing but blood vessel. The blood vessel supplying the kidney will divide into multiple small capillaries in the glomerulus. So we have the afferent glomerulus, so the afferent arteriole, which divides into the glomerular capillaries, and finally it unites to form the efferent arteriole. So the afferent and the efferent arteriole. This entire glomerulus is present in a cup-like structure called as Bowman's capsule, which we know. Bowman's capsule then leads on to the tubules. So the blood which is entering the glomerular capillaries gets filtered, and the filtrate will enter the Bowman's capsule through to the tubules. So why this glomerulus is very important is, we know very well from our discussion in rheumatology that wherever there is blood vessel, vasculitis can occur, right? We discussed about small vessel vasculitis. Glomerulus is also a small blood vessel. It is also a small vessel. So whatever diseases of small vessel vasculitis we discussed, for example, Vijayakumar granulomatosis, it is called as GPA, granulomatosis with polyangiitis. Church-Strauss syndrome, which is called as eosinophilic granulomatosis with polyangiitis. This Vijayakumar granulomatosis has C-ANCA as its diagnostic antigen and P-ANCA as its diagnostic autoantibody. Then we have MPA, microscopic polyangiitis, and many other diseases. So all these vasculitis, then we have something called as Goodpasture syndrome. So all these are nothing but autoimmune diseases, vasculitis. There are autoimmune diseases affecting the blood vessels. So glomerulus is the target or end organ for many vasculitis. So that we must remember. So whenever there is a disease in the glomerulus, we should always evaluate for autoimmune diseases. Then following glomerulus was the first thing. Following glomerulus, we have the tubules. So the first tubule is the proximal tubule. The proximal tubule leads on to the loop of Henle. Loop of Henle has two arms. The thick ascending limb of the loop of Henle, the loop as such. This is the descending limb. The descending limb, the loop of Henle, and the thick ascending limb of the loop of Henle. Following the loop of Henle, we have the distal convoluted tubule. So proximal tubule, loop of Henle, and the distal convoluted tubule. So I can tell everything as the tubules. Tubules are important because they help in reabsorption. So when tubules are problematic, reabsorption is the main problem. So we have multiple electrolyte abnormalities. So there's a separate disease discussion about the tubules. The tubules are present in something called as interstitium, the interstitium of the lung, interstitium of the kidney. Usually tubular and interstitial diseases are taken together. Okay. So the distal convoluted tubules have multiple nephrons end in collecting duct. We have the cortical collecting duct, then the medullary collecting duct. Collecting duct is important for two reasons. One, they are just continuation of tubules. So the same electrolyte disturbances can occur due to collecting duct diseases. And the other important thing is, this collecting duct is the one which finally forms the renal pyramids and the renal pelvis and the ureter. So it is the proximal most part of the post-renal system, or the collecting system, or the ureteric system. So the post-renal diseases, the diseases like post-renal diseases, for example obstruction, BPH, etc., can affect this collecting duct. So some changes can be seen in the kidney even though there is a post-renal disease. So those changes can occur in the collecting system. When collecting system is affected, that can lead to electrolyte imbalance. Just remember one example. If there is an obstructive uropathy, the cortical collecting duct can get dilated and it can get diseased, and this can lead to hyperkalemia. Why hyperkalemia? Because potassium excretion is one major function of the collecting duct. When that is diseased, potassium cannot be excreted, so we get hyperkalemia. So in other words, a post-renal disease is causing an electrolyte imbalance, which is typical of a tubular disease. This we must remember. So the same thing is the basis for distal renal tubular acidosis. There's a disease called as renal tubular acidosis. Some causes of renal tubular acidosis will be obstructive diseases. Then we can tell that there is the vascular system. So what glomerulus we discussed is the small vessels or the capillaries. But we have the larger vessels, the renal arteries and renal arterioles. So those vascular diseases can be there. For example, renal artery stenosis. So we would have heard that renal artery stenosis, if it is bilateral, some clinical points of renal artery stenosis. If renal artery stenosis is bilateral, ACE inhibitor is contraindicated. Second, there are only two main important causes of renal artery stenosis. In young people, it is a genetic cause. So we have cystic medial degeneration. This media stands for tunica media of the blood vessel. So medial degeneration of the blood vessel is the common cause of renal artery stenosis in young adults and young people, and in elderly people it will be atherosclerotic stenosis. So either congenital or atherosclerotic. And what is the clinical manifestation is flash pulmonary edema. The other symptoms of renal disease may not be there, but it presents purely as a flash pulmonary edema. So if symptoms like these are present, we should suspect vascular diseases like renal artery stenosis. So why we discussed the structure of nephron is, if you know the structure of nephron, understanding intrinsic renal diseases will be easy, right? Because intrinsic renal diseases can either be glomerular diseases, tubulo-interstitial diseases, collecting duct diseases, or vascular diseases. So with this basic, let us go to the discussion of individual diseases of the kidney. So the first discussion of individual disease of kidney is AK, acute kidney injury. So acute is something which is occurring less than 6 hours. So it can start as early as 6 hours. So very often we have the notion that whenever creatinine is elevated, there is a kidney injury, but it is not so, because the most important function of kidney is to excrete urine. In acute kidney injury, before creatinine elevation becomes obvious, excretion of urine will be affected. So oliguria is the main symptom of acute kidney injury. Please remember this. In clinical practice or in scenarios when there is given reduced urine output but creatinine is normal, it doesn't mean that patient doesn't have acute kidney injury. Right? Patient can have acute kidney injury with only oliguria. So there is a classification of acute kidney injury or staging of acute kidney injury that is given by AKIN, Acute Kidney Injury Network. This is the AKIN classification. So AKIN 1, AKIN 2 and AKIN 3. As we already discussed, just reduced urine output itself is a diagnostic criteria for acute kidney injury. So less than 0.5 ml per kg per hour for 6 hours is enough to say he has acute kidney injury stage 1. Which means for an example, for a 60 kg person, on seeing hourly urine output, if he is having less than 50 ml per hour of urine, this lasts for 6 hours, that itself is enough to qualify as acute kidney injury. So in stage 1, there is less than 0.5 ml per kg per hour of urine for 6 to 12 hours. Or if at all we see creatinine should rise more than 0.3 milligram per deciliter rise from the baseline. Baseline is nothing but from the previous known creatinine. So that creatinine may be taken the previous day, that creatinine may be taken last month or last year. So whatever is the last available creatinine, that is called as the baseline creatinine. In nephrology, single creatinine has no value. We should always compare it with the baseline creatinine, because creatinine is not the best marker for kidney disease, because creatinine is produced from muscles. So muscle mass varies from males and females. It varies with a muscular person and a lean person. So plain creatinine value alone does not give a hint of disease. Only the baseline creatinine and the rise from the baseline creatinine is significant. That is the reason why we have some newer markers in nephrology. Especially there are some newer markers in acute kidney injury. I am just naming them. One is interleukin 18, KIM, kidney injury molecule, NGAL. So these are some of the newer molecules in and cystatin C. Cystatin C has a role even in chronic kidney disease. So these are some of the newer markers in AK which are better than creatinine. But since creatinine is very commonly used, we still use creatinine. A 0.3 milligram per deciliter rise from the baseline creatinine is AK, or 1.5 to 1.9 times increase from the baseline is AK1. So we have three criteria: 0.5 ml per kg less than oliguria for 6 hours, or more than 0.3 milligrams per deciliter rise in creatinine, or 1.5 to 1.9 times rise in creatinine. AKN2 is the next step of this. So if the oliguria, that is less than 0.5 ml per kg per hour of urine output, lasts more than 12 hours, it goes to the next stage, AKIN2. And here the rise in creatinine will be 2 to 3 times the baseline. AKIN3 is severe. So there is less than 0.3 ml per kg per hour for more than 24 hours, or there is complete anuria for more than 12 hours. We call it as AKN3. Here the creatinine will be more than 3 times the baseline, or the rise absolute creatinine value will be more than 4 milligrams per deciliter. Or if the patient is so sick that he started on renal replacement therapy. Remember, renal replacement therapy is either hemodialysis or peritoneal dialysis or transplant. In acute kidney injury, we don't do transplant, we do hemodialysis usually, or peritoneal dialysis. Transplant is reserved for chronic kidney diseases, few indications. We have 2 types of renal transplant: living donor renal transplant and dead donor renal transplant. Okay, so even if you don't remember the absolute values for AKN 1, 2 and 3, it is enough to know that oliguria less than 0.5 ml per kg per hour for 6 hours, or more than 0.3 milligram per deciliter rise in creatinine or 1.5 to 1.9 times rise from baseline. These three classify as acute kidney injury. So this is the definition of acute kidney injury. Now what are the causes of acute kidney injury? So as already discussed, any renal syndrome has a pre-renal, renal or post-renal causes. So post-renal, as we discussed, any obstruction in the kidney, this is not our concept now. Now pre-renal, we have already discussed hypovolemia, any cause of shock, decreased cardiac output, that is called as acute cardiorenal syndrome, heart failure, liver failure, that is called as hepatorenal syndrome, or any drugs, NSAIDs, ACE inhibitors, ARB, cyclosporin. These drugs affect the circulation, affect the renal autoregulation, hence there will be problems. Then we have the intrinsic renal diseases. As I already told you, how will you classify intrinsic renal diseases? It could be glomerular diseases. So the disease will be acute glomerulonephritis. Then we have tubular and interstitial problems, that is called tubulointerstitial nephritis. So there are many causes of tubulointerstitial nephritis like ischemia, sepsis, then again some drugs. For example, contrast. Contrast causing kidney problem is called as contrast-induced nephropathy. Monoglycosides is the amikacin, gentamicin, etc., which is causing kidney injury. Amphotericin B, it is a drug which is given for mucormycosis or fungal infections that can cause nephrotoxicity. Even PPIs in long term can cause nephrotoxicity. Please remember that. So don't use PPIs for a long term. Then NSAIDs, obviously. NSAIDs is also listed as a pre-renal cause. It can also be a cause of renal injury. Then anything can obstruct the tubules, because main function of tubules, it's a tube, it is reabsorbing. So anything which is obstructing, like myeloma, rhabdomyolysis. In rhabdomyolysis, what happens? Muscles break down, myoglobin gets released, myoglobin crystallizes in the tubules and causes problem. In myeloma, the myeloma cast or amyloid protein, this deposits in the tubules and causes renal injury. Then some drugs cause crystals, for example, acyclovir. It is an antiviral. Indinavir, it is an antiretroviral drug. These drugs can crystallize in the tubules and cause problem. And hemolysis. When hemolysis is more of uric acid is produced, that large rise in uric acid deposits in the kidney. So these are some causes of tubular diseases: rhabdomyolysis, hemolysis, myeloma, and some drugs which cause it, and sepsis and ischemia. Then I told you about vascular diseases: vasculitis, malignant hypertension, and TTP-HUS. What is TTP-HUS? Thrombotic thrombocytopenic purpura. HUS, hemolytic uremic syndrome. Both have nearly the same features. There will be uremia in both. So what is the hemolysis? So because of hemolysis, there is anemia. Here also there will be anemia. Why this anemia occurs is, there is thrombosis occurring within the small vessels. I told you kidney is a small vessel. So there is a small vessel thrombosis which is occurring due to some problem. What is the reason? We will discuss now. So because of small vessel thrombosis, the RBCs which are going through the thrombosed vessels go for lysis. So this hemolysis is called as MAHA, microangiopathic hemolytic anemia. So there is hemolytic anemia. Why there is hemolytic anemia? There is a problem in the small blood vessels of the kidney. So it is microangiopathic hemolytic anemia. Why there is microangiopathy? Because there is thrombosis. So since there is microangiopathy in thrombosis, the diseases of HUS and TTP are called as thrombotic microangiopathies. So thrombotic microangiopathies are also causes for acute kidney injury. So how will you identify it? There will be uremia, there will be acute kidney injury, there will be anemia, there will be thrombosis. When there is thrombosis, there will be consumption coagulopathy. So thrombocytopenia will be there. So thrombocytopenia, anemia, and what happens in hemolysis? LDH will be elevated. So hemolytic anemia, bilirubin will be elevated. We discussed in hepatology, in hemolysis, indirect bilirubin will be elevated. Right? So if there is an oliguria, patient is having indirect hyperbilirubinemia, elevated LDH, anemia, thrombocytopenia, then we can suspect thrombotic microangiopathies, either HUS or TTP. Brain blood vessels, brain capillaries are also small vessels. In TTP, in addition, brain is also affected. So patient can be unconscious or he can be confused. So that is the difference between TTP and HUS. But why does HUS occur? HUS occurs due to O157H7 E. coli infection. This we would have discussed in microbiology. It is a type of E. coli infection. This is common in childhood, which can cause diarrhea. So following diarrheal infection, if there is an AKI, following diarrhea, how all can the kidney be affected? One, diarrhea causes hypovolemia. This hypovolemia can cause pre-renal AKI. This is very well obvious. Diarrhea is nothing but an infection. So that infection is sepsis. So either the sepsis part or the hypovolemia due to hypotension can affect the renal tubules, causing acute tubular necrosis. So this is also a cause of intrinsic renal AKI. If the person is having E. coli O157H7 infection, there can be thrombotic microangiopathy, that is TTP or HUS. This can cause renal AKI. This is due to a vascular cause. The tubular necrosis is a tubulointerstitial cause. So by all these mechanisms, AKI can occur in diarrhea, right? Now why does TTP occur? TTP occurs due to a deficiency of a protein called as ADAMTS13. ADAMTS13 is one protein which is involved in clotting mechanism. At least remember this. It is something associated with factor 8, 1 Willebrand factor. So when ADAMTS is deficient, there will be occurring thrombosis. When this factor is deficient, there will be thrombosis. Just remember that. Right? So TTP, HUS are the thrombotic microangiopathies. So this slide, even though it is complicated, it is easy to understand. So if a scenario is given, the first step is to understand that patient is having AKI. How will you understand that there is an AKI? Patient is having oliguria less than 0.5 ml per kg per hour for 6 hours, and there is a rise in creatinine more than 0.3 milligram per deciliter. If it is there, based on the scenario, we should be able to find out whether it is a post-renal cause, pre-renal cause, or a renal cause. Pre-renal cause, whether it is cardiorenal, hepatorenal, drug-induced, or hypovolemia. If it is an intrinsic renal, see whether there is any glomerular disease, if it is a tubulointerstitial disease, or if it is a vascular disease. We discussed one vascular disease, which is TTP-HUS. We discussed about the deposition diseases, hemolysis, rhabdomyolysis, myeloma, crystal deposition, because the other things we'll be discussing subsequently. See, this is nothing but all causes which are summarized and some clues are given. Just a revision again. In hepatorenal syndrome, there is a primary liver cirrhosis. In liver cirrhosis, what happens? The vasodilators are not metabolized by the liver, so increased nitric oxide causes splanchnic vasodilation. So there will be reduced blood supply to the kidney. So it is also a pre-renal cause. In cardiorenal syndrome, what happens? There is reduced blood supply to the kidney. Automatically, AKI occurs. Then we have something called pulmonary renal syndrome. Pulmonary renal syndrome is not a pre-renal cause. It is an intrinsic renal cause. Like the brain is having small blood vessels, the kidney is having small blood vessels, the lungs also have small blood vessels. So in autoimmune diseases, in some autoimmune diseases, both all the blood vessels are affected. So in Goodpasture syndrome also, lungs are affected, kidney is affected. It is called as anti-GBM disease, glomerular basement membrane disease. Then oncovasculitis. So we discussed granulomatosis with polyangiitis, that is vaginous granulomatosis, or eosinophilic granulomatosis with polyangiitis. In this also lungs are affected, kidney is affected. Plus SLE or IgA, these conditions are also affecting the lungs and kidney. So how will you recognize this? Just remember, in glomerulonephritis, there will be hematuria, bleeding from the kidney. If lung blood vessels are affected, there will be hemoptysis. So if there is a hemoptysis plus hematuria, think of a pulmonary renal syndrome, either Goodpasture or vaginous or Church-Strauss or microscopic polyangiitis. Tumor lysis syndrome we discussed, where the increased uric acid deposits in the kidney. Analgesia, either by causing renal autoregulation changes or by causing direct nephrotoxicity, it can cause a problem. And thrombotic microangiopathy we discussed. In TTP there is ADAM-TS antibody, and in HUS there will be E. coli O157 H57 infection. There is a Shiga protein. Shigella also can cause the same thing by causing Shiga toxin. So what are the features in TMA? Low platelet because of consumption coagulopathy, microangiopathic hemolytic anemia. Schistocytes are seen in peripheral blood smear. It is nothing but hemolyzed blood vessels, hemolyzed RBCs. High LDH and low haptoglobin is also a marker of hemolysis. Don't get confused. Just remember there's something called as haptoglobin. So all this thing is going to affect the kidney. So what are the side effects of or complications of AK? I told you there is reduced urine output. When there is reduced urine output, the entire fluid gets overloaded. So there will be pulmonary edema, hypertension. Uremia can cause damage to the heart. That is called uremic pericarditis. There can be uremic encephalopathy. There can be uremic gastritis. And when chronic, there can be dry skin. So one given in the left, capillary leak is nothing but the intrinsic tubulointerstitial causes. There can be embolization in the kidney also. That's called atheroembolic syndrome. For example, post-cardiac problem, post-cardiac surgeries, this can occur, where cholesterol microemboli can deposit in the limbs as well as in the kidneys. So this is nothing but a gist of the other causes of AK. So again the same slide summarizes it here. So pre-renal, heart failure, renal failure, shock, burns, etc. are the causes. There will be oliguria here. So history will be very obvious in pre-renal. Here there will be concentrated urine. We'll discuss the lab shortly. In renal causes, I told you sepsis, ATN, crush injury causes rhabdomyolysis, myoglobinuria, hemoglobinuria, ischemia, sepsis, contrast nephropathy. Post-renal, any cause of obstruction. So whenever there is an AKI, only few investigations can be done. Definitely we'll be doing urea, we'll be doing creatinine in the blood. So serum urea, serum creatinine. Apart from the urine routine, we can see urine sodium. We can see urine osmolality. Can see serum osmolality. We calculate something called as FENA. FENA is nothing but fractional excretion of sodium, that is urine sodium divided by serum sodium. This is a formula, urine sodium by serum sodium. This whole divided by urine osmolality by serum osmolality. So if we have urine sodium, blood sodium, urine osmolality and serum osmolality, we can calculate this one. Understanding the concept is important. In pre-renal, already there is reduced blood supply to the kidney, so there is oliguria, there is a sluggish flow. So in pre-renal, there is a sluggish flow. Now that kidney is trying to conserve everything. So since there is already a shock, so in shock, two important organs only have to be preserved. They are the brain and the heart. So to maintain perfusion to the brain and the heart, the kidney goes for something called as auto-regulation. So when there is reduced blood flow to the kidneys, the kidney will shut off the urine production and it will try to reabsorb all the water and it will try to reabsorb all the electrolytes to retain intravascular volume. Right? This is the short gist of auto-regulation, which will be discussed in physiology. So what happens? Water is reabsorbed, sodium is reabsorbed. So what will happen to the urine sodium? It will be less, right? So sodium is reabsorbed, urea is reabsorbed, water is reabsorbed. So serum urea increases in pre-renal AKI because kidney is trying to reabsorb more of urea. So urea will be very high in pre-renal AKI. Definitely creatinine will be raised. But since urea is reabsorbed more, the urea by creatinine ratio is more than 40:1. That is what is given here. Urea by plasma creatinine ratio is more than 40 in pre-renal AKI. But the same dramatic rise in urea is not seen if it is a renal cause. Renal or a post-renal cause. So urea by creatinine ratio will be less than 40 in pre-renal AKI. So we will write down urea by creatinine ratio in pre-renal will be more than 40:1, whereas in renal causes it will be less than 40:1. Definitely urea and creatinine will be elevated, but it is less than 40:1. Then I told you about FeNA. FeNA is nothing but urine sodium by serum sodium by urine osmolality by serum osmolality. Or we will take urine sodium first. So urine sodium will be low in pre-renal, right? It will be high in renal. So how much low is? Urine sodium will be less than 20 millimoles in pre-renal and it will be more than 40 millimoles in renal. Likewise, if you calculate the ratio, we get something called FeNA. FeNA will be less than 1 in pre-renal. It will be more than 1 in renal. So everything is tried to be conserved in pre-renal. Everything is tried to be excreted in renal. So that's what is given. Low FeNA, high urea creatinine ratio and a low urine sodium less than 10. Some books it is given 20. FeNA more than 1, urea by creatinine ratio less than 40 and the urine osmolality or urine sodium more than 10 will be renal causes. Then we can see some cast crystals, etc. At least we can remember this one. So this finishes AKI. The next syndrome is chronic kidney disease. So what is called as chronic in kidney disease is when any problem in the kidney lasts more than 3 months, we call it as chronic kidney disease. Or when there is some structural disease in the kidney like a shrunken kidney, that straight away qualifies as chronic kidney disease. Or any urine abnormality lasting more than 3 months qualifies as chronic kidney disease. So likewise in AKI, we have a classification called AKIN. We have KDIGO classification and CKD. This KDIGO classification is based on a concept of eGFR. We know very well that the glomerulus filters and that is measured by something called GFR. GFR is measured by a complex test called as creatinine clearance test. How much of blood is cleared of a substance in unit time, that is clearance. So we have creatinine clearance test. There are some other tests like inulin clearance test, etc. But these are very complex tests, so these are not done in routine clinical practice. Instead, with common measures like creatinine, etc., we can calculate something called as estimated GFR. There are some formulae to calculate this estimated GFR like CKD EPA equation, Cockcroft-Gault equation, MDRD equation, modified diet and renal disease equation. So with some of these formula, we can calculate eGFR. Calculators are available for the same. So normal GFR is 90 to 125 ml per minute per 1.73 meter square of body surface area. This is the formula. So when do you say CKD stage 1? CKD stage 1 is actually normal GFR. So that is renal failure with normal GFR. What is said is in the initial stages, there will be hyperfiltration, or when there is some part of the kidney is diseased, the other part goes for hypertrophy. So there will be increased filtration. That is why, in spite of having a kidney disease, there is a normal GFR. So eGFR more than 90 ml per minute per 1.73 meter square is CKD stage 1. CKD stage 2 is 60 to 90 ml per minute per 1.73 meter square area. Stage 3 is very important. That is when eGFR is below 60 ml per minute. That is very important. Stage 3A is 45 to 60 ml. 3B is 30 to 45 ml. Stage 3 is important because we have to intensively treat from CKD stage 3. So all the drug modifications, bicarbonate supplementation, the preparation for hemodialysis. Okay, so everything begins from this stage 3. The modification, drugs, everything begins here. So that is what is given. So BP control, diabetic control, weight reduction, etc. begins here. Stage 4 is the stage where there is high risk of going to the last stage, and we have to prepare for RRT. So RRT preparation begins at stage 4, which is 15 to 30 ml per minute, and the treatment, intensive treatment, begins at CKD stage 3. When eGFR is less than 15 ml per minute, it is called CKD stage 5, also called as ESRD, end stage renal disease. This definitely requires RRT. It is not that they definitely require RRT. See the wordings, it is highest risk of requiring RRT. RRT is hemodialysis or peritoneal dialysis or renal transplant. So this is the staging of CKD. Now there is another classification which is given. So we can tell that this KDIGO stage 1 to 5 is based on GFR. So it is otherwise given G1, G2, G3A, G3B, G4 and G5. So the same eGFR categorization. I told you not all CKD is same, right? So even though they are in ESRD, based on the etiology, the prognosis varies. So the same stage G3A, but in a different prognosis, different cause, prognosis varies. So what else determines the prognosis is albuminuria. So in CKD, two things only we have to see. One is the estimated GFR. The other one is whether there is albuminuria or not. So normal urine albumin is less than 30 milligrams per day. Less than 30 milligrams per day. So if there is CKD with normal albumin, that is A1. When the protein is 30 to 300 milligrams per day, that is called A2. When the protein is more than 300 milligrams, we call it as A3. Okay, so less than 30, 30 to 300, more than 300. So you can see, if it is G1 and there is no albuminuria, it is safe. But the same G1, if there is an albuminuria, there is a risk of progression. So just you have to understand this. We have to see always two things in CKD, eGFR and albuminuria. Now what are the etiologies for CKD? The most common etiology worldwide is diabetic kidney disease. Then we have glomerulonephritis. So an intrinsic renal disease which is causing chronic kidney disease is glomerulonephritis. Remember, glomerulonephritis can also cause acute kidney injury. It can also cause chronic kidney disease. Then hypertension is the third common cause. Then ADPKD. we have a discussion on ADPKD shortly. So ADPKD is autosomal dominant polycystic kidney disease. It's a tubulointerstitial disease. It's a chronic tubulointerstitial disease. So these are the 4 common causes of CKD. So most of the chronic kidney diseases will be intrinsic renal diseases. So I was discussing RRT will be hemodialysis or peritoneal dialysis or renal transplant. In hemodialysis or peritoneal dialysis, the concept is simple. We take out the patient's venous blood, pass it through a membrane. That membrane filters instead of the kidney, and the filtrate has the cleared blood that will be entering the arterial end. So follow my arrow mark. This is hemodialysis. Something called as AV fistula is created, usually in the hands. So radiocephalic fistula, brachioradial fistula is commonly created between the radial artery and brachial vein. So following this fistula creation, from the venous side, blood is taken and it enters the dialysis membrane or dialysis filter. This membrane filters the blood. It removes the excess water. It removes excess electrolytes. It removes the creatinine. It removes bicarb. So many of these are removed by the filtrate, and the remaining blood is pushed back into the arterial system. This enters the blood. So the kidney's function is done by dialysis filter or dialysis membrane. If it is done by a machine, we call it as hemodialysis. The same filtration is done by a natural membrane, usually in the peritoneal cavity. The peritoneum is used as a membrane. That is called as peritoneal dialysis. It is commonly used nowadays. It is called as CAPD, continuous ambulatory peritoneal dialysis. The patients will be trained to do it on their own, and it can be done in home at the comfort of the patient. So hemodialysis is usually getting converted to peritoneal dialysis now. If this dialysis is not done, then we have renal transplant, either live donor renal transplant or dead donor renal transplant. There's a separate protocol, separate follow-up for this, because even though patient is transplanted with the kidney, the problem of transplant rejection is common. There are many types of rejection, and patient should be on lifelong immunosuppression. Immunosuppression may be with steroids, or it may be with immunosuppressants like azathioprine, mycophenolate mofetil, tacrolimus, etc. Having discussed about dialysis, so these are some may come as questions. This disease is called as calciphylaxis. So some changes occur in the body due to long-term dialysis. One is calciphylaxis. So this is nothing but calcium deposition in the skin. It will be causing skin necrosis like this. And this is another thing called as tumoral calcinosis. Chronic hemodialysis causes this one. Chronic hemodialysis causes many other problems. Like there can be cachexia, so we have to give high protein diet. Usually in CKD we give low protein diet. But following hemodialysis, they should be given high protein diet because their catabolic rate is very high. There are some problems with acute dialysis, acute complications of hemodialysis. One thing is, because large amount of water electrolytes are removed, we have something called as dialysis disequilibrium syndrome. So large amount of fluid and electrolytes are removed, so this can cause acute electrolyte imbalances, seizure, coma, etc. So this dialysis disequilibrium syndrome is treated with fluid and electrolyte replacement. Specifically, mannitol can be used. Usually mannitol is not given in CKD because it cannot be excreted, but in this condition, dialysis disequilibrium syndrome, it can be used. Now, since we discussed two syndromes, AK and CKD, I told you in these diseases we have intrinsic renal diseases. So we will discuss about intrinsic renal diseases affecting the glomerulus. Okay, so glomerular diseases can be classified as nephritis, also called as glomerulonephritis, nephrotic syndrome, RPRF, rapidly progressing renal failure. See, these are actually specified clinical entities. Definitely, AK and CKD can occur, right? If there's a glomerular disease, it can cause AK. That we have discussed already. So, we'll remove this one. Chronic glomerulonephritis or chronic glomerular diseases cause CKD. That is also well known. But these are also specified entities. These are also kidney diseases or specific symptomatology. What is this nephritic prototype is hematuria, proteinuria, hypertension, mild edema or edema. This hypertension can be so severe that it can cause some changes in the brain like hypertensive encephalopathy. Glomerulonephritis is dreaded because it can affect the brain by this one. Okay. Nephrotic syndrome is a prototype where there is no hematuria, but there is massive proteinuria. Massive proteinuria will be more than 3 grams per day. So when there is more protein excreted, what will happen to the blood albumin level? Hypoalbuminemia. So massive proteinuria, hypoalbuminemia. Low albumin is one cause of edema. So there will be severe edema. Edema is mild in glomerulonephritis, but it is very severe in nephrotic syndrome. Plus some other features occur. At least remember these things. So massive proteinuria, hypoalbuminemia, severe edema, but no hypertension. BP will be normal in nephrotic syndrome. RPRF is rapidly progressing renal failure. We discussed about acute kidney injury. More than 0.3 milligrams per deciliter rise from the baseline creatinine is this one. RPRF is more than 50% rise in creatinine within days. So within 2 to 3 days, if the creatinine rises from 2 to 4, it is RPRF. Now, we already discussed if a patient is having a scenario of oliguria, we rule out post-renal cause. We rule out the pre-renal causes. Then we think of the intrinsic renal causes. Intrinsic renal causes, we can get some clues from the basic examination. For example, if you do a urine analysis by seeing hematuria, proteinuria, by seeing RBC cast, we can find out that patient is having a glomerulonephritis. Okay, suppose another example, if a patient is having anemia, if the patient is having thrombocytopenia, elevated LTH, we can label patient may be having TMA. Right? So if a patient's evaluation of AKI or a renal disease shows that he is having glomerulonephritis or a nephrotic syndrome, we usually do biopsy. Of course, there are some conditions with only blood investigations we can treat. For example, in pediatrics, 2 glomerular diseases are only common. In glomerulonephritis, the common disease will be post-streptococcal glomerulonephritis. So following a streptococcal sore throat, there will be glomerulonephritis. So usually PSGN is the common glomerulonephritis in pediatrics. And there will be, if a disease comes like a nephrotic syndrome, the commonest disease variant involved here is minimal change disease. So usually in these conditions, we do not do renal biopsy because these are very common, these are very classical. But in adults, we usually do biopsy. Or if there is some atypical features in pediatrics, we do biopsy. Okay. Right. Why biopsy is done? Because there are many types. So I have given you 7 diagrams. There can be 7 histological variants here. Okay, so we will discuss here. So the first one is PSG. I told you post-streptococcal glomerulonephritis is the commonest cause of glomerulonephritis presentation in pediatrics. In fact, most common glomerulonephritis overall. So I'll just tell the pathological findings very shortly because those will be detailed pathological discussion. So what happens is there will be subepithelial humps. That will be the picture which is seen. Okay. So usually when we do a biopsy, we see light microscopy. And there we have to pick up some findings. Then we see immunofluorescence, because I told you most of the glomerulonephritis will be immunological diseases. So we have to see immunofluorescence to see what type of deposit, whether it is IgA, IgM or IgG, or what type of pattern, which antigen is getting targeted. Then we have electron microscope. This is the gist. So in light microscopy in PSGN, we get something called as epithelial humps. It is usually proliferative glomerulonephritis, so many cells will be there. So PSGN is one type of nephritis. Another type of nephritis is IgA nephropathy. The name itself suggests. IgA diseases is usually a vasculitis. So this IgA vasculitis, example is Henoch-Schönlein purpura. It usually causes GI bleeding. It usually causes hematuria and skin vasculitis. So here there will be IgA deposition in the mesangium. That is the clue. It doesn't deposit in the epithelium like light microscopy. It deposits in the mesangium. So I'll write it as mesangial deposit of IgA. Then we have something called as MPGN, membranoproliferative glomerulonephritis. So it is also a type of glomerulonephritis. So we'll discuss three variants of glomerulonephritis. Usual one is post-streptococcal or post-infective, or the latest term is given as IRGN, inflammation-related glomerulonephritis. IgA nephropathy usually occurs in a bit elderage. So clinically we can differentiate PSGN and IgA like this. Usually post-streptococcal glomerulonephritis occurs more than 1 week after a streptococcal or a normal throat infection or a skin infection. Whereas this IgA nephropathy occurs less than 1 week after infection. Right? So if there is hematuria, edema within 1 week of another infection, it is usually IgA nephropathy. If it is occurring more than 1 week, it is usually post-streptococcal glomerulonephritis. How will you prove? By doing biopsy. Right? So there is something called MPGN. There are some types of MPGN. We are not discussing it. So the name itself suggests there is membranoproliferative. So there are some pathological findings which we will not discuss for now. Then what about nephrotic syndrome? So likewise there are three pathological variants of nephritic syndrome. We have three pathological variants of nephrotic syndrome. One is called as minimal change disease, MCD. Then we have MN, membranous nephropathy or membranous glomerulonephritis. Then we have FSGS, focal segmental glomerulosclerosis. This is a normal glomerulus. The name minimal change disease is given because there is no change in light microscope. There is no change in immunofluorescence. Only in electron microscopy we see effacement of podocytes. That is why it is called as minimal change disease. But see FSGS is focal segmental glomerulosclerosis. A segment of the glomerulus is sclerosed and fibrosed. That is called FSGS. This can be seen in nephrotic. Another one is membranous glomerulonephritis or membranous nephropathy. There is proliferation along the membrane. So some specific features are seen here. RPRF, rapidly progressing renal failure, has the histological finding of rapidly progressing glomerulonephritis. When something is rapidly progressing, there will be excess proliferation. So if you see more cells, more exudates, everything will be there. So that is what is RPRF. So remember, there are the 7 pathological types: post-streptococcal glomerulonephritis, IgA nephropathy, membranoproliferative glomerulonephritis, cause glomerulonephritis. Then in nephrotic syndrome, we have minimal change disease, FSGS, and membranous nephropathy. RPRF, we have separate feature. If you have to have more detailed discussion on this one, you can refer to pathology textbooks. This is just a orientation on this one. So just see the images here. So this one is membranous nephropathy. I told you membranous nephropathy is seen in nephrotic variant. See, there is deposition along the membrane, right? That's why we are seeing linear deposits. Next one is IgA nephropathy. I told you IgA nephropathy is a mesangial deposition. There will be glomerulonephritis-like picture within 1 week of a throat infection. There will be mesangial deposits. See, the mesangial deposits will be like clumps in immunofluorescence here. Then anti-GBM disease. Anti-GBM disease is also glomerulonephritis, right? So as the name suggests, here there is antibodies against the glomerular basement membrane. So how will it look? It will look like a linear deposit in immunofluorescent, and its pathology will be looking like this. Lupus nephritis, there are 5 types. Lupus nephritis is renal disease occurring in SLE. So here there are 5 pathological subtypes: minimal mesangial, mesangial proliferation, focal nephritis, diffuse nephritis, membranous nephritis, and sclerotic nephritis. So the name itself suggests. So in lupus nephritis, we have some terms given. Wire loop deposits. Deposits will be wire loop, and in immunofluorescence, we call that deposition as full house effect. That is, all types of antibodies are deposited. IgM, IgG, IgA, everything is getting deposited. In IgA nephropathy, only IgA deposits, right? But in SLE, lupus nephritis, everything deposits. So I just gave an orientation regarding how to read the scenario and how to look for the findings. So I'm not discussing the detailed pathology. Similarly, if a scenario is given on nephrotic syndrome, try to look at the light microscope, because here immunofluorescence has no role. See, this looks like a nearly normal glomerulus. So if the light microscopy is nearly normal, it is minimal change disease. But only an electron microscopy will pick up effacement of podocytes. This is the commonest variant of nephrotic syndrome in pediatrics. Then FSGS. So you can see there is only a part of the nephron is proliferating, and there's a sclerosis. It is focal segmental glomeruloscleritis. Membranous nephropathy, there will be some changes like duplication of membrane, etc. So how will you treat glomerulonephritis? One, we are treating the cause. Steroids, initially it was given, nowadays it is not used. The main treatment in glomerulonephritis is hypertension control, because it causes hypertensive encephalopathy. How will you treat nephrotic syndrome? Usually minimal change disease is steroid responsive. So we give steroids. If they are steroid dependent, we give immunosuppressants like cyclophosphamide. Okay, that's just the gist about the treatment. See, this is how we evaluate nephrotic syndrome. I told you there are 3 main variants: minimal change disease, focal segmental glomerulosclerosis, and membranous glomerulonephritis. Of course, membranoproliferative also can come. So if there is a minimal change disease, we have to rule out other conditions also. If there is FSGS, we have to rule out diabetes, obesity. Membranous nephropathy usually occurs due to an antibody called as plaque2R. If possible, you can remember. And it can occur secondary to many drugs like gold, NSAIDs. Gold is not used nowadays. Gold was used in traditional medicine to treat some skin diseases. Nowadays, it's not used. Mercury, it causes mercurial poisoning, right? So many traditional medicines, they mix mercury and give, so that excess mercurial compounds can cause membranous nephropathy. So that's why kidney becomes important. In poisoning due to fake traditional medicines, there can be problems. So gold, mercury, and in our medicines, ampicillin, NSAIDs can cause. SLE can cause membranous nephropathy. Malaria can cause. Cancer can cause. MPGN also we have primary causes and secondary causes. And this is about RPGN. So I told you RPRF pathologically will have RPGN. RPGN is classified into 3 types. So pauci-immune deposits, that is ANCA immune disease will be one, anti-GBM disease is the other, and low C3 conditions will be the one. In most of the glomerulonephritis, it is important to see C3 and C4, because usually C3 will be low in conditions like PSGN, but in SLE, C3 and C4 both will be low. These are the complement deposits, right? So how will you evaluate a glomerulonephritis? By doing biopsy, that is the main thing. Then we can do C3, C4, and we can follow up the response. So this was just a gist about how to understand the diseases, glomerulonephritis versus nephrotic syndrome versus RPGN. So if there is a glomerulonephritis, think of a PSGN or IgA nephropathy, the common one. If there is a nephrotic syndrome, think of minimal change disease, FSGS or membranous nephropathy. So all of these can be primary or secondary. If there is an RPGN, think of ANCA mediated, anti-GBM mediated, low C3. So most of the RPGN will be pulmonary renal syndromes, right? Most of the RPGNs will be pulmonary renal syndromes, either Guttmacher or pauci-immune diseases like GPA, Vicinous granulomatosis or Church-Strauss syndrome.